A nuestra comunidad socia de ADM les informamos que a partir de hoy se implementará una nueva forma de registro para adquirir sus constancias al tomar las pláticas vía Facebook. La nueva dinámica es la siguiente. Primero, ingresar al link que dejaremos en la descripción de la transmisión en vivo, así como en un comentario fijado en la misma. Segundo, llenar el formulario que le aparecerá al entrar al link. Tercero, presionar el botón enviar y listo. Les sugerimos revisar bien todos sus datos para que queden escritos correctamente. A nombre de IDA Academia les damos la bienvenida a un nuevo miércoles en casa con el doctor Jaime Edelson. En esta ocasión contamos con la presencia de dos invitados de honor. Me permito presentar al doctor Mark Wolff, decano de la Escuela Dental de la Universidad de Pensilvania y consejero de la Asociación Dental Americana. Es licenciado en Ciencias y Biología y doctor en Cirugía Dental por la Universidad Estatal de Nueva York, doctor en Filosofía, Biología Oral y Patología por la Universidad Estatal de Nueva York. Cuenta con un amplio currículo dentro de su experiencia profesional, además de haber participado en un gran número de libros y artículos alusivos a la práctica odontológica. El tema que estaremos abordando el día de hoy es el presente y el futuro de la educación dental después de COVID-19. Pueden enviarnos sus preguntas para que nuestros invitados tengan a bien responder todas sus dudas. Los invitamos a seguirnos a través de las redes sociales de IDA Academia y a compartir este video con útil información. Les recordamos que esta charla tiene un valor curricular de 2 horas para socios ADM.
Hola, muy buenas tardes. Nuestros invitados de hoy son el doctor Mark Wolff y el doctor Michael Glick. Our guests this afternoon are Dr. Mark Wolff and Dr. Michael Glick. Dr. Wolff, thank you, and Michael, again, thank you for being with us and help us connect with these important people of worldwide dentistry. Le agradezco mucho al Dr. Michael Glick el hecho de que nos ayude a conectarnos con personas tan importantes de la odontología mundial. First of all, Mark, I want to thank you for being this morning with us. And let me tell you a story. I went to Yukon in the late 70s, and all the prosto teachers were the grandsons of Morton Amsterdam. And back in those years, going to Penn University was like going to Mecca or going to Jerusalem or going to the Vatican. It was one of the biggest names in my school years. And so this gives me a double pleasure to have you as a guest this morning. Le agradezco mucho al doctor Mark Wolff haber aceptado. Cuando yo estudié en Connecticut, la Universidad de Penn era semejante en una religión a ir a la Meca o ir a Jerusalén o ir al Vaticano. Era el centro del conocimiento. Y el doctor Morton Amsterdam fue una persona que inspiró a muchos maestros de prótesis, la famosa prótesis periodontal de esa época. y me da por eso un doble orgullo estar aquí esta mañana con él. El doctor Glick también fue dean en Penn y después fue dean en la Universidad de Buffalo. Michael, you were also dean at Penn and then dean at the University of Buffalo, no? And
I was a professor at Penn. I was a dean of
professor.
Buffalo.
Okay, so but anyway, I think that.
And by the way, I'm a recovering dean right now.
I'm very glad to have you both this morning because I think you are icons of dentistry, and in particular in one of the toughest areas of dentistry, which is the training of new dentists. Yo considero que ambos, Michael Glick, que dice que es está como en recuperación de Dean, él abandonó el puesto de director de la Escuela Dental de la Universidad de Buffalo, y qué mejor que tener a estas dos personas que son grandes íconos de la odontología mundial y en específico de la academia, y que nos platiquen cómo ven ellos el futuro de la educación dental en general. No sé si pudiéramos quitarla eso. Ya nos fuimos. Recuerden que estamos totalmente en vivo y estas cosas pues a veces suceden. We are totally live. This is not a dress rehearsal, like live. And so, Mark, would you like to make a first round of ideas on what's happening today in your school and what's the future is going to look like in your opinion? Just remember, you give me a few ideas, I translate, because we don't have immediate translation, okay?
Okay. So thank you for having me. It's a wonderful opportunity to speak. Certainly outside the United States and around the world, this is wonderful.
Gracias por invitarme a participar en esta forma de salir de Estados Unidos y comunicarme con gente de todo el mundo.
So it's a wonderful position to be dean leading a school of dental medicine like a University of Pennsylvania.
Es increíble ser
el
director y llevar el timón de una escuela como la Escuela de Medicina Dental de Penn. Es un gran honor y una oportunidad.
So today, Penn Dental Medicine is seeing a very few patients with critical needs who are in pain, infected, or have bad damage to teeth.
En este momento solo vemos emergencias o cosas muy urgentes o gentes con dolor o que tienen realmente problemas severos.
The majority of our care today, the majority of our school today is working to teach our students remotely. So just like this, we sit opposite each other through a screen.
Y en ese momento también la mayoría de las clases, todas las clases son a través de una pantalla como esta, donde nos comunicamos maestros y alumnos.
The role of dean has changed from just looking at how to create great education and make that possible within a school to being an educator-in-chief for staff, faculty, and students on the disease of COVID-19.
Y ahora me he vuelto el educador en jefe de una serie de alumnos y maestros que quieren compartir el tema principal, que es este que nos aqueja, que es el del COVID-19.
So today we've transformed our education program into an online communication between faculty and students.
Y hemos transformado nuestro sistema educativo en una comunicación remota entre alumnos y maestros.
This is a burden for dentists who have to do procedures to learn learn adequately.
Y este es un gran problema cuando nosotros sabemos que tenemos que entrenar a los odontólogos, a los dentistas, para que hagan el trabajo presencial.
So today within the United States, we have a minimal amount of testing available to see who has the disease of COVID-19, yet we have a very high burden of patients who have this disease.
Tenemos una falta de pruebas suficientes en los Estados Unidos para poder saber quién sí tiene y quién no tiene la enfermedad.
Our government has imposed social isolation on our patients, and it requires them to stay at home.
El gobierno ha implementado este quédate en casa como una regla.
The same applies to our students and faculty.
Y la misma regla aplica a nuestros maestros y alumnos.
So today we're confronted with the issue of how do we begin to come back to treat patients as part of the education program safely for patients, faculty, staff, and students.
Y nos enfrentamos al reto de cómo vamos a regresar a nuestra fase clínica con un altísimo nivel de seguridad, tanto para nuestros maestros, alumnos y pacientes.
All of this is being done while we're so a lot of what we're forced to do is in interpreting best practices related to infection control.
Y todo esto está sucediendo en tiempo real, donde estamos realmente aprendiendo las diferentes fases que tiene esta enfermedad y solamente podemos recurrir a las mejores prácticas de cuidado, de barreras de protección y no para evitar las infecciones cruzadas.
Mark, can I ask you a
Please.
question? You have a facility with multiple dental operatories. It's not a place with one or two. You have multiple operatories that have a certain distance in between the operatories. Until now, we had universal precautions that are based on blood-borne diseases. How do you address, in your situation, with multiple operatories and airborne diseases?
Michael nos pregunta, le hace la pregunta al doctor Wolff, de cómo las universidades ya tienen están construidas de cierta manera, donde se guardaba la distancia suficiente para enfermedades transmitidas por sangre. Y ahora, ante esta nueva situación, que son enfermedades transmitidas por aire, ¿qué medidas piensan implementar o se podrán utilizar sin tener que destruir una clínica y volverla a construir?
So that's a great question, but Michael, I'll push back on one predicate, that we've only protected against bloodborne pathogen. We deal with patients that have the flu all the time, and flu is a very deadly disease.
Quisiera regresar también a hacer, es muy buena la pregunta, pero voy a hacer un predicado que ya existe. A pesar de que nuestros sistemas están hechos para no contaminarnos con enfermedades que se transmiten vía sangre, pues también atendemos muchos pacientes que tienen la influenza normal, que también ha resultado ser una enfermedad muy letal en temporada.
So the question becomes, how do we manage an airborne disease in an environment that dentists create more aerosol as part of what we do in practice?
Y el verdadero reto es cómo vamos a poder implementar o ampliar estas medidas en un ambiente donde el dentista él solo genera muchísimos aerosoles.
Now, the discussion of aerosol has actually, and the discussion of this disease has shifted fairly rapidly. Initially, we thought of patients that had a cough, that had a temperature, that had been in contact with somebody as being the major determinants of who had the disease. Today, we know there's a lot of people who also have the disease that may be subclinical.
En un principio se hablaba de que las personas que podían infectar a otras eran las que tenían los síntomas iniciales, fiebre, una tos muy fuerte, dolor de cabeza, dolor de garganta. Pero hoy sabemos que andan por ahí muchas personas totalmente con síntomas subclínicos que no sabemos que tienen la enfermedad y que nos pueden contagiar.
So is this changing dental education in any way, that we are looking at different type of procedures, or less procedures, or maybe do more in typodonts, or are we doing the same thing and we just changing somehow or adapting the infection control procedures? How do you see education in the future when this is becoming an endemic rather than a pandemic?
¿Y cómo sugieres que vamos a poder resolver esto cuando ya sea una situación común, porque la enfermedad no se va a ir, y más que ser un problema pandémico, va a ser un problema endémico?
So I think we're going to have to teach people and learn how at the same moment to treat people that may have a condition of various infectivity, and we're not positive actually how infective dental byproduct is in the process in care. So first, we're going to have to learn a totally different level of infection control.
Primero vamos a tener que aprender un completamente nuevo nivel de infección, de control de infecciones, precisamente porque no sabemos el impacto que este tipo de pacientes va a tener dentro de la odontología. Let me just make a comment, Mark. In the mid-80s, with patient zero in Florida, where we all thought the dentistry was going to die, because how could we treat patients with the HIV? And I remember back then that the premise was that we treat every patient as if they were infected. And we didn't choose, is he infected? He isn't, because it's discriminating, number one. And number two, it was just the profiling based on a lot of social biases. And I think it went well for dentistry. We changed from using gloves, things that we didn't do because we were trained without them, into trying to do the best. Of course, you had to stay away from needles, from cutting yourself with the same blade, etc. Le pregunto a Mark que a mediados de los 80s, cuando surgió el problema del VIH, un aspecto que a mí me gustó mucho, en el momento de tener que aprender a trabajar con guantes, porque fuimos entrenados sin ellos, sin barreras de protección, sin muchas cosas porque no existían. Bastaba con cuidarse de no clavarse una aguja de anestesia o no contarse con un bisturí o con un punzocontarte en eso, pero no hacíamos selecciones, no decíamos a este no lo trato porque tiene HIV, o hacíamos este puede tener o no hacíamos lo que se llama hoy profiling, sino que tratábamos a todos como si todos tuvieran, y creo que ese fue el éxito. Just to the last sentence. We treat everybody like if they were infected in order to don't cross contaminate and be safe at the same time, right? So this doesn't apply to coronavirus?
We call it universal precautions. And universal precautions, as it turned out, when you speak with Dean Bien from Wuhan University, an epicenter of where the disease started, we find that dentists who didn't even know that all of these people who had this condition, only one dentist got sick using universal precaution, and there's question whether or not the precaution was actually adequate at that particular moment. Were they properly using it? So even in an infected country where dentists were active in treating patients, it turned out that a massive number of dentists did not get this disease. And that's an important commentary on universal precaution, which is what came out of our AIDS, HIV era concerns for infection control.
Let us translate.
Jaime,
yeah.
let me just continue that just one thing here. Sorry to interrupt you. What you didn't mention when you introduced Mark is that he is one of the absolute world leader in karyology. And he ran one of the largest dental clinics at NYU, where thousands and thousands of patients were treated at the same time and over time. So my question is to Mark is, fine, infection control procedures will be the same, but can we minimize aerosolized procedures in dentistry? Can we do something differently when we treat patients to minimize aerosol, meaning changing the way we practice maybe? And that could be one of the lessons we learned from this pandemic.
Now, let me, I have short memory amnesia, so let me just make a summary of what happened here in Spanish. Nos comenta Mark que durante el inicio de la infección en Wuhan, la gente iba al odontólogo, iba al dentista, y de todas las gentes que fueron con infecciones, solamente un dentista que aplicaba las medidas universales de control de infecciones se contagió. No fueron miles. Entonces, esas medidas de inicio son buenas, tendrán que mejorarse con la experiencia y con el tiempo cuando vayamos conociendo al enemigo, por decirlo de alguna manera. Y Michael me recuerda que no mencionamos que Mark es experto en cariología y que manejó en NYU una de las clínicas donde se atendieron miles de pacientes en ese tiempo donde empezó a haber estas medidas universales. Pero Michael le pregunta si es el momento de repensar toda la odontología generadora de aerosoles. I think I did more or less the summary.
So, will dentists be expected to minimize aerosol? It's interesting. We've been hoping they would minimize aerosol for decades related to cariology, and not drill holes in teeth quite as often.
Let me translate. En efecto, no solamente por el coronavirus, sino en general, llevo años intentando, bueno, la odontología también, que se minimicen los procedimientos de aerosol, que los dentistas usen mucho menos las piezas de mano al tratar lesiones cariosas. Entonces, por eso le aplaudí, porque creo que es algo tan intrínseco de la odontología que se hagan cavidades donde no hace falta, que también es un momento donde muchas cosas pueden cambiar. I emphasize the fact that, you know, it's not, many dentists were not educated, were trained in drilling and filling. That has been the hardest part to get rid of. But this is a time of many, many opportunities. And one is to really shift to all those preventive non-aerosol measures that can be taken to treat caries. Because many people think that caries is a class 1 or a class 2. You know, one thing is cavitation, one thing is how to deal with caries.
Well, so, you know, just as examples, use of sealants on early lesions instead of picking up a handpiece, drilling, creating all this aerosol, use of fluorides on incipient and lesions that haven't penetrated to dentin, well researched and well confirmed as the best treatment for the patient. Now maybe dentists are going to view this as best treatment for them, so they expose themselves less to aerosols.
Dice, finalmente es posible que los odontólogos aprendan que esas prácticas donde utilizamos barniz de flúor para recalcificar superficies del esmalte y la utilización de selladores que no llevan consigo una gran cantidad de aerosol. You know, the aerosol is minimal because you still have to wash and dry a little bit the acid etch procedure, but es mínima la cantidad de aerosol que se genera con esos procedimientos y esperamos que esto realmente sea el tiempo de oportunidad de cambiar hacia esos tratamientos. Michael, I see you're just vroom.
No, I teed it up for Mark and he hit it straight out. I think it was excellent. So so I can see how education is changing in the sense that we are going to now to start to look at prevention much more than treating a disease, obviously. Silver diamond fluoride is another example, and so on and so forth. So Mark, do you see this going to be a trend in dental education? Hopefully, eventually it's going to prevail into the community of dentistry as a whole in the future?
Le pregunta a Michael a Mark si cree que realmente la utilización de fluoruro de diamina de plata o otros barnices de flúor y otros medicamentos que van más hacia lo preventivo, realmente van a ser el parteaguas en cambiar nuestra manera de atender a nuestros pacientes.
I believe that all of these, whether we're talking about minimum intervention dentistry, smaller holes when we do choose to drill, less aggressive dentistry. You know, you spoke about Crown and Bridge and Morton Amsterdam and University of Pennsylvania. Big dentistry was a norm at one time. I think we're going to move away from that.
So you think, bueno, dice Mark que vamos a ir hacia la invasión mínima, que ha sido una tendencia que ha sido difícil de insertar en las prácticas. Probablemente porque a los dentistas no nos educan, sino nos entrenan a base de repetir y repetir y repetir procedimientos. Mark, do you have an opinion on if dentistry should start to be taught instead of trained? You know, you have your dog, you send the ball, and the dog comes back with the ball in his teeth. So you're training the dog to do tricks. And for years, I've been against this concept of training by repetition and with not enough emphasis on educating dentists. Do you think it makes a difference? Le pregunto si realmente hay una diferencia entre entrenar al dentista o educarlo. Entrenamos a un perro a aventarle la pelota y la trae de regreso y por la repetición lo hace. Nos enseñaron a hacer cavidades, a obturarlas y por repetición lo hacemos. Eso es un entrenamiento. Le pregunto si hay ahora la oportunidad que yo siempre he abogado que a los odontólogos nos eduquen en vez de entrenarnos. What's your feeling about it? And you too, Mike.
Patients are becoming more complex with disease. Our care needs to very carefully be guided by best practices. And I think it's absolutely critical that we start the pattern and start the behavior of teaching dentists to actually treat patients, not holes.
Estoy muy de acuerdo en que sí, debemos de, aunque siempre hemos tratado de hacerlo así, es un momento de realmente educar a nuestros estudiantes a tratar pacientes y no a llenar cavidades, agujeritos.
And you know, these things are, it's even part of how we speak. I don't know how you do it in Spanish, but we talk about the root canal patient or class 2 amalgam patient. We have to get away from that stuff. That's not what it is. It's a patient that has a disease that we need to get rid of. It's not the procedure that makes a difference. It's the disease that makes a difference.
That's precisely what I mean by training.
Yeah.
And it's training by repetition. And, you know, the people who flunk and have an extra year have a better opportunity to get trained better.
Or they also have an opportunity to see their failures. So maybe dental education should be increased a couple of years. So we not only see our successes, but our failures as well.
Mike dice lo mismo. Desde la parte universitaria es muy común decir, necesito una endodoncia de 3 canales o necesito una restauración MOD. Y no hablamos de pacientes con una enfermedad que tienen que ser tratados, sino hemos precisamente abusado incluso en el lenguaje, en esta forma de que no es atender los problemas de los pacientes, sino como individualizar, te cambio una clase 2 por una endo de un conducto, ¿no? Ese es el lenguaje que usamos desde la universidad y que deberíamos de cambiar. Any on this subject?
Yeah, dentists think of themselves as surgeons doing things. They don't think of themselves as diagnostic and treating. They like to treat the outcome of the disease, not as much as treating the disease. And I don't care whether it's periodontal or caries or cancer. They don't think about how do we prevent this? How do we make the patient better?
Mucho en la odontología también se refiere a que estamos dispuestos a resolver el daño, a entrar y resolver, y no necesariamente a diagnosticar ni a ampliar el pensamiento de por qué se presentan esta u otra situación. We are firemen and renovators. ¿No?
Yeah,
Le digo que somos bomberos y remodelador de interiores.
Yeah. So one of the problems we have, at least in the United States, is we get paid by a procedure code and not by a diagnostic code. So in English, you say, if you're a hammer, everything is a nail. So if you
En
have
Estados Unidos, el reembolso de los seguros es a base de procedimientos, no del resultado de llevar al paciente de la enfermedad a la salud. Y como dice un dicho americano, para el que tiene un martillo, todo tiene cara de clavo. Let me ask you something else. All this new trend that dentistry was going into, you know, the democratization of cone beams, access to do a lot of diagnostic without really performing any what we used to call exploratory surgeries. Now it can be solved by this. And the United States in a faster pace because of the economy. In Mexico on a slower pace because of the economy. We were getting into the digital world. Is it an industry that it's very, very much treatment driven? Is it going to support a big change like we are, you know, in this very small talk, we have probably a couple of thousand dentists listening. Le pregunto, en Estados Unidos ya había un gran avance en la digitalización de la odontología, precisamente por la economía en que se encontraban tan bogante. En México, obviamente, con menos rapidez el ingreso de la odontología hacia el camino digital, pero estará en una industria que está muy orientada hacia la restauración, hacia la estética, con un fin funcional, sí, pero una parte fundamental de la industria está dirigida a la restauración. ¿Podrá la odontología soportar este cambio tan paradigmático? This is a very paradigm change going to you know, aesthetic dentistry and restorative dentistry at full speed, which is some of the reasons that many dentists go into dentistry. Like Michael said, I don't know if we can pay our loans from dental school just by doing diagnosis and fluoride varnish. Many dentists go into this because of the restorative part, no?
Restorative is the sexy part of dentistry. We would be remiss to believe that the dentist who we all attend those courses where they put up on screens 10 feet tall, this is what the tooth looked like before, this is what the tooth looked like after. I don't get thousands of dentists to listen to me talking about fluoride. They get thousands of dentists to look at, let's change this smile.
Yeah. Well, Sheldon Stein. Remember Sheldon Stein? This is nature, this is Stein. This is God, this is Stein. And it didn't look as good as they look today. No, sí, hablamos de que dice Mark que la parte sexy de la odontología es la rehabilitación y que ahora sí nos enfrentamos a a algo que puede ser un cambio paradigmático. You know, aesthetic dentistry is elective in many ways.
Oh, yes.
I don't agree with that.
Aesthetic dentistry is not elective by the patient?
No, and I'll tell you why. If you look at the definition of oral health that came out of FDI, a patient's self-confidence, able to smile,
yeah,
etc. That shouldn't be elective. That's part of what is needed. We call it elective. We call it plastic surgery, but it can dramatically affect the patient's life. It shouldn't be an elective procedure in that sense.
Bueno, aquí tenemos una discrepancia, Michael y yo. Yo digo que la odontología estética en muchos momentos es electiva. El paciente elige arreglar su sonrisa. Sin embargo, me recuerda que en la nueva definición de salud bucal de la Federación Dental Internacional se hace énfasis en la importancia de sentirse bien, de la autoestima. Y en ese sentido, la odontología estética deja de ser un procedimiento estético y para muchas personas puede ser esencial. Yes, I agree. I just thought that it could be elective in a way that, I can postpone it for a year, wait to see what happened, but still it's going to affect dentistry in general.
So I think that dentistry emerges coming back looking like it did months after a vaccination to immunize you against COVID-19. I think dentists will gravitate back. As soon as they're safe, they'll start treating patients in a somewhat different fashion. And I think that patients may have a different sense when people feel safer about it. And we've seen this with polio, and we've seen this, people didn't want to go to dentists and people during summers and things like that when they thought that polio was at its highest peak. We see that.
Sí, dice Mark que eventualmente cuando existe una vacuna y el dentista se sienta seguro, pues también regresará a llevar a cabo cualquier tipo de tratamiento y que los pacientes también estarán seguros una vez que se sientan que tienen una vacuna, o como él comentaba hace rato, hay ahora la idea de que la gente se ponga, el que ya tuvo coronavirus se ponga una pulsera y pueda decir, yo ya tuve, ¿no? But both are educators, and did you have a particular speech with your students when this came up? Have you had the chance to really talk about not the ethics, not the moral, forget that, just the sense of, you two, we share the same shampoo, and I just have a little of a glue today because otherwise I look like a crazy lion. I haven't learned. I have the machine, but I haven't really have the guts to try it on me. But was there a special thing that you told your students when this started, or when we really saw what impact is really was this really going to have on dentistry? Les pregunto a los dos como educadores si hablaron con sus estudiantes, no desde el punto de la ética, la bioética o la moral, sino sus propios sentimientos hacia el impacto que iba a tener cuando ya se supo realmente qué impacto podía tener el coronavirus en la sociedad, si les dieron algún mensaje especial a sus alumnos.
I mean, the biggest question our students had, how am I going to finish the requirement so I can graduate?
They have, but you didn't share any thoughts?
That's what's their biggest concern.
Bueno, los estudiantes lo que más les apuraba es si se van a poder graduar. Well, they were already in debt, like what, $400,000. So.
Yeah, but then add to in the state of New York, in order to get a license to practice, you need to practice a year postgraduate. Now, that might impact greatly who's going to not only finish dental school, but who will be able to get a license to practice. So this may change a lot of different things. I don't know, at the University of Pennsylvania was different, but that was the biggest concern of our students.
So students are interested in what it will take to graduate. That's very important to them. They were actually interested in what dentistry will look like going out in the future. And is what they're learning today going to be what they're going to actually be able to practice tomorrow? And I think that was a very important conversation. I meet with each class of dental students for 1 hour every week this way for the last 7 weeks, so that we can talk about where things are going, how we expect to see them changing.
Ambos, como educadores, les pregunté qué han hablado con sus alumnos, y pues claro, los que están por terminar o los que están a la mitad, su preocupación principal es cómo van a hacer para terminar, cómo se van a graduar. Sin embargo, Mark también nos comenta que él se reúne con sus alumnos 1 hora a la semana para platicar de estos temas, de el miedo, de cómo se va a ver la odontología cuando esto termine o en las diferentes etapas. And there are a lot of questions on particular ways of treating.
I have to ask Mark one more question.
Sure.
So Mark, are we looking at the new normal or new abnormal?
New abnormal.
Estamos ante una nueva normalidad o una nueva anormalidad. Mark está de acuerdo con Michael que se trata de una nueva anormalidad.
Which means things will change.
I think that things will temporarily change. I think as soon as we know more about this disease, more about how contagious it is in the dental environment, my sense is we're going to go back to right where we were, maybe as quickly as 6 months, but definitely a year, 18 months, I don't think we're going to look different in dentistry.
Dice Mark que él no cree que dentro de un año, año y medio, el mundo dental se vaya a ver diferente de como era antes de la pandemia, que él cree que podremos regresar a la normalidad en 6 meses. Well, that's the coronavirus pandemia, but the economic pandemia, it's another story. People who had money or had money, besides what your insurance pays, which is not much, may slow the recovery of dentistry, don't you think? Te comento que en Estados Unidos la gente que no tiene trabajo, aunque haya conservado su seguro dental que cubre muy poco, pues que va a hacer que sea más lenta el regresar a las épocas pre-covirus.
Dentistry faces 2 distinct issues. Issue number 1 is, will the patient feel safe coming into the dental office? And HIV/AIDS was actually a great example of when people felt uncomfortable going into the dentist.
Sí, en esta primera etapa será como en la época del VIH, donde la gente tenía miedo de ir al consultorio dental.
Some surveys that have been run by hospital systems say that almost half the patients would delay care 6 months, given the opportunity, even when they had been scheduled for surgical care just prior to the event.
Muchas personas que ya tenían la cita para algún tipo de cirugía están viendo la manera de retrasarla, aunque ya tienen la cita y la hicieron antes del virus, porque hay mucho miedo en la gente. People are afraid of getting close to a hospital.
And I'm going to call it the fear factor.
The
fear factor.
Y eso le llamaría yo el factor miedo.
I think you have to be very healthy to go to a hospital today. Otherwise you won't survive.
Michael agrega que hoy en día hay que estar muy sano para acercarse a un hospital.
So we have faced recessions. I hate to admit to nearly 40 years of dental practice. Over 40 years of dental practice, I can think of 4 or 5 major recessions that have taken place. And this is probably the worst we have faced. But after each one of them, dentistry has come back stronger than it ever was before.
Con casi, aunque me dé pena decirlo, casi 40 años de práctica en el mundo de la práctica dental, hemos pasado 4 o 5 recesiones muy fuertes. Obviamente esta es la más fuerte, pero yo espero que como en todas las anteriores, la odontología salga fortalecida de esta parte del conjunto del miedo, la economía y los contagios. It's the triad the new triad is fear, economy, and
so Mark, based on what Jaime is predicting and what you are saying, do you think that will result in less dentists graduating? We're going to slow down and have smaller classes because we might be less patients in the next coming year, so less dentists might be better for dentistry than continue to educate so many dentists that may not have enough to do?
Michael pregunta si esto va a tener un impacto en que menos personas quieran estudiar odontología y que sean menos los odontólogos y por ende también tengan un beneficio adicional en que no se estén inyectando nuevos odontólogos al sistema cada año. How many dentists are pushed into the world every year in the U.S.?
US is about 6,000
Per year?
per year. And the number of total dentists practicing in the United States has actually been shrinking just slightly because of retirements. I think that the economy may slow down dentists, retiring. I think that the infection control may speed up. I can't tell you what the net effect will be. I'm too old to deal with this. I can't make the change. I'm out, or I'm too poor to get out. I'm going to keep working. I don't know which one.
Bueno, me comenta que aunque el número de dentistas que trabajan en Estados Unidos se ha ido reduciendo porque se retiran, y ahí se gradúan 6,000 nuevos odontólogos cada año en los Estados Unidos, y que es muy difícil saber cómo va a ir. Hay personas que van a decir, no me quiero adaptar a los nuevos tiempos, tengo miedo, ya tuve suficiente de odontología, y se retiren antes. Y otras personas, la economía los obligue a trabajar muchos más años de lo que se hubieran podido retirar. Well, I think that also difference in this economic pandemic is that the United States was going on a ultrasonic train of the economy. So in Spanish, we have a song that says, it's a song about the boy and a girl. The girl name is Mariana. It says, entre más alto subimos, Mariana, nos duele más la caída. The higher we go up into the sky, you and I, Mariana, the bigger is the drop, the fail.
So in recession, Jaime, the dental profession actually made out better, not better than it was when the economy was roaring, but versus other professions, people need dental care. What we offer will be different, but people are still going to need dental care.
Dice, y tiene razón, las personas siempre necesitarán la odontología, y eso será un punto a favor de la recuperación de la parte dental con respecto a otros. But you don't know yet that you don't build your practice on a toothache. People that go to the dentist when they have a toothache, you get rid of the pain. A lot of them don't come back. I think dentistry is supported by the people who really think that their mouth is as important as it is and take care of it with seriousness. And that's when I include what Michael said about feeling better and then straightening your teeth, not only for aesthetics, also for function, for health. So it's a combination, but it's we're certainly gonna consume more as Zantac probably between now and a normal day in the office. Digo que vamos a tener que usar mucho Melox, mucho Zantac, de aquí a que sea volver a un día normal en la clínica.
This is going to be uncomfortable for patients. It's going to be uncomfortable for dentists. I practiced for 36 years, and we did aesthetics was my major portion of practice. But during recession, we took care of a lot more toothaches, and those turned out to be the loyal patients that returned when the economy returned.
Sí. Dice que cuando en recesiones, pues sí, a veces se van los pacientes de las rehabilitaciones completas, pero la gente que se rompe un diente, que se estresa, que aprieta, que tiene dolor, pues son también leales en esas épocas en lo que se recupera la economía y el factor miedo. I have a lot of questions on laser.
Sure.
Do you think this is the path to a new way of treat using lasers? Hay varias preguntas que me envían aquí de la producción que hablan de si es la oportunidad para que la odontología sea tratada con láser.
So great question that has an evasive answer. So when we look at using lasers on warts on the skin, there was a tremendous amount of fear actually raised for the surgeon because the viral particles that actually cause this were not killed by the laser. And as a result of that, we put it up in the air, right in the face of the operators. So,
hay casos en que para quitar algún algún crecimiento que tenemos en la mano de origen viral, cuando se quita con láser, también había los cirujanos que lo quitaban con láser también tenían miedo porque el láser no mata al virus y sí genera it's an aerosol after all.
yes.
Riega como un aerosol al ir cortando para quitar esas lesiones en la piel.
So it's actually a more dangerous aerosol because it's not attached to water typically, and that makes it easier to penetrate our masks, easier to penetrate into our respiratory system. It doesn't fall as quickly.
Y como en muchos láseres no utilizan agua, entonces es más fácil colocar una gran cantidad de virus en el aire que penetren, entren a nuestros ojos o atraviesen inclusive las mascarillas por no estar en agua porque caen de inmediato.
We'll have to learn more about it. I've used laser to treat dental caries and treat patients. It's a different treatment, maybe. I don't know. I wouldn't run out and buy one because of this disease at the moment.
Dice, yo he tratado muchas lesiones cariosas con láser, sin embargo yo no saldría en este momento corriendo a comprar uno. We have to go through we want to run, we want to go too faster than the coronavirus.
Yeah, but don't forget what Mark alluded to before. We are building the airplane while we're flying it at the same time.
Sí, como dice Michael, es como si estuviéramos construyendo el avión al mismo tiempo que vamos volando en él.
Yeah, so we are learning while we're practicing, and we're going to know much, much more while we're practicing and from practicing. So that's what I mean by we are building the plane while we're flying it at the same time. In the end, we will figure it out, but we have much more to learn.
Como dice Michael, y hemos repetido, tendremos que ir aprendiendo en el camino y es un gran aprendizaje. Now, is it true that you can sanitize articles, not yourself or up your, the ultraviolet light, like someone said last week? But can we use ultraviolet light to sanitize our dental chairs, our the working tables in the office?
There's not looking at Corona SARS, the SARS-V1, looking at other similar viruses. They do appear to be susceptible to ultraviolet light. The question is, how much, how long does it have to be in place? There are a lot of good disinfectants, whether we're talking about lots of the spray disinfectants that we routinely use. Most of the chlorine-based have been shown to be quickly effective. That being said, I think certainly putting an ultraviolet light as you walk through the door isn't going to sterilize the patient in any way. And keeping those in your room, as you're working, I'm not convinced would have any net effect.
Well, Nuva light lasted like 2 years, 3 years. And it was gone because of the effect on your finger when you.
Yes, well, we weren't wearing gloves, and we were getting all sorts of growth and problems on our fingers at those times.
Sí, la pregunta era
Jaime, what we should do is we should actually practice outside as soon as the summer comes, because that's going to kill the virus.
You sarcastic person.
La pregunta era si podemos esterilizar nuestros operatorios y las clínicas con luz ultravioleta. Nos dice primero Mark que no hay pruebas todavía suficientes de cuál sea el efecto de la luz ultravioleta sobre el coronavirus en específico. Sí se ha demostrado que puede terminar con otros virus. Recuerden que una persona la semana pasada muy importante en los Estados Unidos recomendó que usáramos la luz, que la metiéramos al cuerpo por donde pudiéramos y que iba a servir. Obvio, eso no es. Y Michael agrega que
You don't need to translate it.
pero que poner un arco de luz ultravioleta en el consultorio no va a destruir los virus en el paciente mientras pase por ese túnel. Dejarlo adentro del operatorio tampoco es conveniente. Y yo les recordaba que el primer ejercicio de un composite que se endurecía por luz fue el sistema Nuva Light de Kolk, que utilizaba luz ultravioleta. Y como se trabajaba sin lentes y se detenían las matrices de celulosa para hacer una clase 3 o una clase 4, empezó a haber crecimientos de pequeños cánceres de piel en los dedos de los pacientes.
I have another question for Mark afterwards.
Estaban constantemente irritando con luz ultravioleta la superficie de los dedos del odontólogo. Al paciente no le pasaba nada y desaparecieron. Go ahead, Mike.
What do you think about testing a patient before you see a patient? Should we do COVID-19 testing of patients?
I think that's first, let's presuppose that doing a nasal or a salivary or a throat swab will tell us whether a patient has COVID-19. There's lots of discussions about that. Let's presuppose that. We need to balance cost. We need to balance whether we're culturing it while the patient is active or not active, likely to give us the disease. And if it's simple and cost effective, it would be a very easy way to make everybody feel more comfortable.
Would you treat the patient differently based on the outcome of the test?
That's a disgusting question, but great. The truth is we're going to use the ultimate in PPE, the patient protective equipment anyway.
Yeah. Bueno, aquí la discusión que están teniendo Michael y Mark es, Michael le pregunta si la clínica dental debe ser el lugar para llevar a cabo las pruebas. Todos sabemos que están llenas de asegúnes en las pruebas, hay ventanas donde ni siquiera el PCR marca un falso positivo y todavía nos aparecen los inmunoglobulinas, entonces no sabemos si también es un falso negativo de parte de las pruebas serológicas. Pero nuevamente volvemos al principio de que debemos tratar a todos como si estuvieran infectados, de tal manera de no bajar jamás la guardia. We have to treat everybody as if they were infected, so we shouldn't just ease up the measures.
Yeah, but when it comes to testing, Jaime, if I'm correct, you have a wonderful video on testing that people can access, right?
You stole my... hay un trabajo sobre las diferentes pruebas, la verdad hasta el día de hoy, que fue realizado por el doctor Michael Glick y yo hice la traducción. Lo pueden encontrar en mi Facebook, creo que ya también está en el de la Asociación Dental Mexicana, y lo pueden encontrar en YouTube buscando Michael Glick Test or Testing, y ahí encontrarán la versión en español traducida por un servidor y la versión en inglés de Michael. Y luego nos pueden decir cuál les gustó más. I'm telling them to see yours and mine and then tell which one was better.
Okay. Is your with your picture and mine with my picture as well, or without picture?
No pictures. There's a question maybe we answered already, Dr. Wolff. Can you tell me how you reduce the aerosol generation in your practice or at your university?
Yeah, so the first thing is use the high-speed handpiece or the ultrasonic scaler as little as possible. When you use it, use a rubber dam, high-speed evacuation as much as possible.
Bueno, pues lo que hay que hacer es, si van a tener que utilizar aerosoles, utilizar un dique de hule bien puesto y utilizar succiones de vacío específicas, no el eyector de saliva que no tiene fuerza, sino una buena succión que en México le llamamos succión quirúrgica para poder atender pacientes. Is sterilizing our operatories with ozone an option? There are machines that push ozone into the surfaces, and could that be an option? ¿Podría ser una opción utilizar máquinas generadoras de ozono para esterilizar el operatorio o el consultorio en general entre un paciente y otro?
I'm going to be very careful in answering the question because nobody has actually tested this on the COVID virus. But there are lots of oxygen generating technologies that are becoming available or are available that are thought to be effective against other similar viruses.
Quiero ser muy prudente al contestar esta pregunta porque no existen estudios específicos del ozono sobre el coronavirus y además no hay por ahí ya muchos productos generadores de oxígeno que han sido probados en otros virus con éxito, pero que, repito, no han sido probados en COVID.
We also need to distinguish between sterilizing and disinfecting.
Yes, thank you, Michael. We're talking about disinfecting, definitely not sterilizing.
Y estamos hablando de desinfección. En ninguna manera debemos utilizar la palabra esterilización, que es algo completamente diferente. Fue mi error al traducir. Y también recordemos que, otra vez, estamos aprendiendo en el camino. Let me see. Wait, well, in this part, I have a few more, and we almost have to finish. Oh, this is a toughie. How would you evaluate your students' competences development if they cannot practice in patients?
It's a great question, and I don't think that you can know whether a dentist has gained competency without reviewing the process of treating patients. I think patient care is an integral part of it. Whether it's managing your fear, whether it's how I communicate with you, and it's how I do a procedure. We need to know that they are able to deal with people in a gentle fashion. I don't think we can separate the patient from this, and I don't think a dental school will exist or thrive on simulation alone.
Creo que es una pregunta muy interesante y muy importante porque decía, ¿cómo va a evaluar a sus estudiantes en el desarrollo de competencias si no pueden practicar en pacientes? Y Mark comenta que esto es algo que jamás podrá ser sustituido ni por robots, ni por hacer cosas in vitro. Es también aprender a tratar al paciente como un ser humano, sus sentimientos y el papel tan importante que juega el paciente en general en el desarrollo de este trato entre el estudiante y su paciente. We're on the hour. I don't know if you want to make some closing remarks. Something that we left outside. Después, si nos hacen una última ronda, porque ya estamos sobre la hora.
I'm so happy to have been able to do this. I need to thank Michael again and Jaime. I'm impressed that the whole world is working to better understand this changing environment.
Le agradezco mucho a Michael y a Jaime el darme la oportunidad de estar aquí con ustedes. Me impresiona mucho que todo el mundo está realmente unido en este interés por saber cómo vamos a poder continuar con nuestra labor. Michael, you?
Yeah, I think Mark mentioned a couple of times the HIV pandemic and how that changed dentistry. And I think here again, we need to be looking at this pandemic, take a step back and see how this pandemic can make us better dentists in the future. Because there are opportunities here, how we can change things for the better. Prevention is just one single example, but it's a great example. And I think we should take it to heart for two reasons. Number one, because we can be better. And number two, this is going to happen again.
Quiero resaltar que Mark ha hablado varias veces sobre cuando apareció el VIH y que cómo eso hizo que la odontología se practicara mejor. Hoy son nuevamente tiempos de oportunidad, de salir fortalecidos, de seguir estudiando, seguir aprendiendo. Es una gran oportunidad para que la odontología preventiva tome un vuelo importante. You see, if you wash your teeth, you're not going to have to be so often to my office, ¿no? Es decir, si te vas a cuidar tu boca, pues a lo mejor no vas a tener que venir tan seguido conmigo, ¿no? Ese sería un slogan sarcástico. Mark, I want to use the opportunity. I don't know what's the future of dental congresses. We have a very important one in Mexico that is going to be a mixture because the one in May was canceled, which is done by the National University. And here in front of everybody, I want to invite you, if the times allow it, to be our guest. Michael has been here a couple of times. He probably will be back again. We're forcing him to do things he never did before. Those lectures have immediate translation, so you won't have to wait for me to translate. There is an official translator. And I didn't know that Michael had so many important friends. And cardiology and the change of paradigms for the future is certainly going to be a very important factor. You know, we didn't talk about the amalgam, which for me it's the biggest opportunity of dentistry to get rid of such a teeth destroyer from the past, because there was nothing else but towards the future. Again, a lot of opportunities. We hope you join us in November. We'll do we hope that by then we can, maybe we're not going to hug, but certainly we're going to have tequila and we'll meet you, and you're going to meet a lot of good Mexican friends. Lo estoy aquí comprometiendo.
Tequila can kill the virus, right?
Only if you gargle for 10 minutes and then swallow.
Okay.
1 minute. Aquí lo estoy comprometiendo, Mark, para que en caso de que pues se pueda llevar a cabo el congreso de ADM con AMIC, va a ser con la UNAM también, con FOLA. Va a ser un gran evento de la odontología para regresar en un año donde habrá muy pocos congresos presenciales. Esperamos que para entonces ya está y que Mark pueda acompañarnos y hablar de su pasión, que es la cariología. And maybe by then we also have a lot more information on what this, and if this happens between now and then, we probably do the same. We're going to move to a night schedule after the end of May, because people will be hopefully back to work during the day, even though if it's going to be like many countries, 1 patient per hour or whatever, so you don't have, you know, it's very... I did a video yesterday in my office, all empty, all dark. You know, it's a place that it's always with very loud music and good coffee. I think that's what makes a good practice: strong coffee and loud music. But anyway, I thank you both very much. Les agradezco muchísimo. Y los invito, la próxima semana vamos a tener un invitado también muy especial, el doctor, el maestro Salomón Chertorivsky. Él fue secretario de Salud de México durante el fin del sexenio de Felipe Calderón. Fue el creador del Seguro Popular, que hoy ha sido destruido o lo han cambiado por una idea que no funciona todavía. Y él dirigió el cuarto de guerra durante la pandemia del H1N1 en el año 2009, y creo que va a ser muy interesante. Nos va a platicar qué pasa con el coronavirus en México, qué pasa en la comunidad dental y qué pasa en el individuo. Vamos a ir del macro al micro. If you want to join us next week, we're going to have a past Secretary of Health of Mexico during the H1N1. It was not a pandemic, but it was what should we call it? An infection that started here in Mexico. He was in charge of the war room of the Mexican government that treated the problem completely different that we are doing now. This today is crazy. Sometimes we wish we had Trump. We can do a trading if you want. we have a disastrous government. But anyway, thank you, Michael. It's good to see you always. Mark, very nice meeting you. I'm sure this is not going to be the last time we meet, and I hope you can travel in November and join us in a hallway. I think it's going to be a comeback for dental congresses. People would like to go to dental congresses and meet friends. So if dentistry needed a push, maybe this is the one.
Looking forward to a changed world again. Thank you very much. Everybody, please stay safe and healthy.
Todos quédense seguros y sanos.
And part of staying healthy, make smart decisions.
Okay.
Take care.
In the name of IDA Academia, we would like to sincerely apologize for the confusion with the data we shared with you during the presentation of our guests. We allow ourselves to correct the information, thanking Dr. Michael Glick, who is professor of the dental medicine at Buffalo State University of New York, author of more than 300 publications, president of the American Board of Oral Medicine, and currently editor-in-chief at the journal American Dental Association. We would also like to thank Dr. Mark Wolff for this participation and for sharing with us his experience in the topic of present and future of the dental education after COVID-19. And we will also like to thank Dr. Jaime because he's with us every Wednesday and he allowed ourselves to have this space with you.
Gracias. Thank you. See
En
you
nombre
next
de
week.
IDA Academia, extendemos una sincera disculpa por la confusión de datos proporcionados durante la presentación de nuestros invitados. Nos permitimos dar corrección agradeciendo la importante participación del Dr. Michael Glick, profesor de la Escuela Dental de Medicina de la Universidad de Buffalo, Nueva York, autor de más de 300 publicaciones, quien ha fungido además como presidente de The American Board of Oral Medicine y actualmente es editor en jefe de The Journal American Dental Association. Asimismo, agradecemos al Dr. Mark Wolff por su participación y por compartir con nosotros gran parte de su experiencia en el tema, el presente y el futuro de la educación dental después del COVID-19. De igual manera, extendemos nuestro agradecimiento al Dr. Jaime Edelson por permitirnos aperturar los micrófonos un miércoles más y abordar temas de alta relevancia en el contexto mundial. A los socios ADM les indicamos que en este momento finaliza la recepción de datos para la obtención de constancia. Esta transmisión estuvo patrocinada por Ideas Dentales. Gracias a todos, los esperamos a la próxima.
Hasta la vista.